So hello and welcome to this final oral evidence session for the ARMA Musculoskeletal Health Inequalities Inquiry. We know that the incidence of MSK conditions is not equal. There are inequalities for a range of ways of sex, ethnicity, age, social economic deprivation, a whole range of factors, intersecting factors that actually make this quite complex. We decided, for the purposes of this inquiry, just to make the topic manageable, that we would focus on people living in areas of deprivation, but we do understand that that intersects with a whole range of other issues. As I said, this is the final of 4 oral evidence sessions, and if you've not seen the other 3, the recordings are available to watch if you would like. We plan to finish writing the report of this inquiry at the end of this year. So next year we will be launching the report and we'll spend a year or more disseminating the information and the recommendations and trying to get some action taken. I would like to thank for their support Grunenthal for sponsorship of this whole project, Pfizer Limited, Novartis Pharmaceuticals and Janssen for charitable grants towards the project. None of those supporters have had any say in the way the project is run or the topics that we're discussing. So today's session, as I said, is part of our evidence gathering, and I'm really delighted to round off this evidence gathering phase of the project. Andy Bennett, Bola Owolabi and Aoife Malloy. And I'm going to ask each of them to introduce themselves in turn so that we can see the different perspectives they will bring to today's session. So Andy, can we start with you?
Thanks, Sue, and thanks for convening us and for the work you're doing in this space. So my name is Andrew Bennett. I am National Clinical Director for Musculoskeletal Conditions for NHS England. My substantive role / day job is as a consultant physiotherapist within community MSK services in Sutton, southwest London.
Thanks, Andy. And Bola, would you like to introduce yourself?
Thank you, Sue. Colleagues will be delighted to know that I had to save myself from a wasp sting, hence having to get it out first. Look, thank you so much for convening us and for the invitation to be here. Hello, colleagues. I'm Bola Owolabi. I'm Director for NHS England's National Healthcare Inequalities Improvement Programme, and I also work as a GP in North East Derbyshire. Great to be here.
Thank you, Bola. And Aoife, finally.
Hello, everybody. Lovely to be able to meet and discuss all this today. My name is Aoife Malloy, so I'm a consultant in infectious diseases and acute medicine in the Royal Free Hospital in London. And I also work as the Senior Clinical Advisor for Healthcare Inequalities Improvement with Bola. Really glad to be here today. Thank you.
Brilliant. Thank you all for joining us. Our previous sessions have all been on very specific aspects of this topic, but it's brilliant to bring together expertise around health inequalities and expertise around MSK to just round off this evidence gathering. So the place I wanted to start was data. We have heard a lot about the importance of data to people being able to work on this, but we've also heard quite a lot from MSK services who are really keen to tackle this, but they're struggling to know where they go to find the data. And some of them are finding quite convoluted workarounds to try and gather the data that they need. So I'm wondering what advice you might have for where people would go who are really wanting to do this properly and wanting some data to help with that. Bola, I know that's something that you have spoken about before, so I wonder if you want to start with this one.
Thank you, Sue. I think my first reflection would be we must at all costs avoid what I describe as paralysis by analysis. You know, we can always say we need more data. I would suggest that we have a lot of data already. Particular example, the Osteoporosis Society. They've mapped out the availability, for example, of different therapeutics for osteoporosis by ICS level. It's actually really, really powerful data, you know, talking about fragility fracture clinics and their availability across the country. Just one example. Our own Core 20+5 approach, where we've asked each of the 42 integrated care systems to especially focus energy on the Core 20 plus population group. So the Core 20 particularly, that is based on postcode, and that data is available. You know, it's based on the 20% most socioeconomically deprived population groups by the index of multiple deprivation. That data is readily available. OHID publish health inequalities data. We've got the fingertip tools. We have the National Healthcare Inequalities Improvement Dashboard. I would suggest that it's about committing to starting somewhere in terms of interventions, rather than us allowing the quest for more data to create inertia.
Thank you. I think that's a really key point as well, of not waiting for the perfect data before you start trying to do anything. Aoife, did you have anything you wanted to add to that?
I would very much echo Bola's statement, that we have so much data. It's almost about kind of bringing it together and triangulating the evidence. And, I was really thinking that a lot of the sort of work around musculoskeletal health is to do with long-term management of pain and mobility. And we know that, pharmaceutical treatments, for pain are really for the symptoms, but they're not going to do anything in terms of curing. But we do know that sort of overprescribing and prescribing of dependency forming drugs and polypharmacy is really concentrated in the groups of people who are already living with healthcare inequalities. And we know from the Versus Arthritis report that a lot of women from the lower socioeconomic groups, as defined by the index of multiple deprivation, are suffering with pain at a much earlier age and with much less access to the treatments. And when I'm talking about treatments, I'm talking about really getting access to alternatives to pain medication. So this is really a problem around equitable access and examining our routine data, as Bola said, through the National Healthcare Inequalities Dashboard, can really give a really strong picture of the inequity that's there. So it's really time to act on the data and really bring it together and keep on making the case for a change.
Thanks, Aoife. And Andy, can I ask you about MSK services specifically? So we've heard from quite a lot of community MSK services that they do struggle to work out where they can get the data from. And obviously, community MSK services are provided by all sorts of different providers. Some are provided through hospital trusts, some are provided through independent third sector organisations, some are provided through private companies. Do you think that those that are provided by non-NHS bodies struggle to know how to access the NHS sources of data? And is there anything that, say, ICSs can do to improve that flow of data?
Thanks, Sue. To answer that question, I'll just briefly answer the first question as well from an MSK perspective. That's okay. So we have lots of data. MSK is also a very broad church. It's about how we use that data, stratify it, and have it in a way that we can enable both assurance and quality evaluation. And we need to think of MSK within the three sort of domains that we've talked about within the major condition strategy. So you've got your conditions of MSK pain, back pain, osteoarthritis, etc. You've got your osteoporosis, as Bola quite rightly alluded to. Then you've got your inflammatory arthritis. And of course, the chronic pain agenda, as Aoife talked about, is intrinsically related to that, given about 84% of people with chronic pain attribute it to the MSK system. So the three big resources I would go to from a national perspective to start off with is the OHID Public Health Fingertips database, as Bola quite rightly mentioned. It is a really valuable resource. You can look at outcomes related to long-term MSK conditions, OA, hip and knee, back pain, hip fractures, and relate them to geography, relate them to levels of deprivation, relate them to areas of primary prevention, obesity levels and physical activity, it is a really strong resource that is publicly accessible. The second thing is our model health system data. Now that's less publicly accessible, that's for people who work in the NHS, but that is a data-driven improvement tool that helps NHS systems and providers to benchmark quality and productivity. Very much in the secondary care space, but there is some bits of that data set that I've talked about previously that can relate to primary and community delivery. And then we do have our national audits. Bola quite rightly mentioned the work in osteoporosis. That's driven by our falls fragility fracture audit, and that's informing the work the ROS do. And we've got the early inflammatory arthritis audit, and the reports from those are publicly accessible. So there's quite a lot of stuff in MSK. But moving on to the second question, there are gaps in our ability to use data. So we have data, but use it to quality evaluate and assure in the conditions of MSK space and in primary and community care. And I would say that's where the biggest challenge within MSK is moving forward, to have a healthcare system that fits for the future, but also to address disparities. As a result, data collection often occurs locally, as well as the stratification of data. And that requires a collaborative approach between commissioners, providers, working with their analysts. And we do have a published improvement framework for community MSK, which starts to nod towards things we should be collecting from a data perspective. And also on our Best MSK Health Futures resource, which is still there, has a really good section on data and suggested metrics to collect in primary and community care. But to the second question, you're right. The challenge at system level, so at integrated care system level, is there's often multiple providers of MSK services using different digital information technologies with different requirements with regard to collecting data and measuring some elements of their performance. And that creates massive challenges for ICBs because they need to understand the nature of the different providers and how the commissioning level is working at place. And I think that's something we need to pivot around as we move into the recovery and transformation of MSK services moving forward. And I think, to be fair, the development of ICBs is our opportunity to do that, but we're very much at the early stage of that process.
Brilliant, thank you very much. And just for anyone watching from outside England, the aim is that this report will cover all 4 UK nations, and we will be trying to work out what the equivalent data sources are in the other nations when we write up the report. So what in addition to the sort of the data bit of knowing your community, we've also heard some services who seem to have a really good and rich understanding of the community they are serving, that is not based on data, but is based on the understanding of the patients that they see. So one service that covered quite a wide, complex and varied geographic area could identify the different health-seeking behaviours in each of the patches and places within the area they served. How important do you think this is for this work? And also, there's more of a challenge for that for services that cover a big area. So we heard that this is very difficult to do for paediatric secondary care services that cover massive geographical areas. Andy, do you want to start with that one? Have you got any thoughts?
So this is incredibly important, and this is certainly a challenge we need to work through. And I think to achieve this, there are some key principles which are applicable whether we're covering a large geographical area or indeed an area which is small and intensely populated. Firstly, the population health approach to evaluating need, designing public health strategies and delivering care is really key. Secondly, the ability to co-design working with stakeholders across health and social care, as well as the voluntary and community sector. Thirdly, co-production with those with lived experience, and that's diverse lived experience. And fourthly, an understanding of an ability to effectively deliver personalised care and behavioural change. And I think those principles relate to system design and quality evaluation, whether it's a large geographical area that perhaps is sparsely populated, or whether it's a tight geographical area where there is different demands. We still have the same challenges that we alluded to with MSK wider, and I can see in the chat someone's talked about the challenge in the children's space, and I agree that challenge is there. But really, what we want to get to, I think, is equity in outcomes and value of provision, but that done in a heterogeneous way and not a one-size-fits-all model, because actually how we have to deliver health services, let alone MSK services, in a sparsely populated large geographical area has to be different in how we deliver it in a densely populated inner city area, but the outcomes need to be the same. And so it's the principles that underpin that, which can be shared across both, that can be adapted and adopted in different ways. And I hope that answers the question, because I kind of went off on.
Well, that's fine. That's good. Thank you. Bola, did you have any thoughts on this one?
Yes, thank you. And I will add to Andy's principles another one, which is to consistently have health equity as one of those principles. Because the thing is, people do listen to these things, and the more we reiterate at every opportunity that in addition to those really important principles that Andy has just outlined there, to explicitly call out health equity would be really powerful. And if I was to unpack the health equity principle then, in addressing your question about whether we're working across a large geography or not, I agree with Andy that actually the principles remain the same. I would suggest that we take a quality improvement approach. And that quality improvement approach is across 3 dimensions. First of all, is that we pivot to using the data to drive specific interventions with a view to improvement. And that's a very particular way of handling the data. I think historically, we often use data for assurance or for evaluation. And it's not to say these things aren't important, but the thing that we need to increasingly become more adept at is to use data to drive improvement. We call it creating virtuous circles of data, whereby we use data to gain actionable insight. What are we going to do? And for that actionable insight to lead to some very tangible interventions. And from those interventions, hopefully we drive improvement, and we're able to work out intelligence about what works and keep doing what works and stop doing what doesn't. That's the first thing in terms of taking a quality improvement approach. So number 1, data for improvement through virtuous circles of data. Number 2 is to take a strengths-based approach. So all too often we talk about the challenges, which means we don't always see the opportunities. So the communities that we are trying to reach, there are many opportunities in these communities. We only just need to reframe from the challenge to the opportunity, as we did during COVID vaccine deployment. We suddenly realized that in these communities, not all, but significant proportions, faith was a powerful part of identity, community leadership. And we took those 2 strengths and built on it. And it actually helped us to absolutely move the data in the right direction. The third in that bucket list of quality improvement methodologies, as Andy mentioned, is co-production. Because the people and the communities that we're trying to reach, they have the most creative, innovative, sustainable, and cost-effective ideas about what to do if we ask them. So I think taking a quality improvement approach to this is another way in, regardless of whether it's a large urban population or coastal or rural, whatever description. I think if we can apply those 3 QI methodologies consistently and have health equity as one of our underpinning principles for the work. That will take us much further forward.
Thank you, that's really helpful. And Aoife, did you have anything you wanted to add on either of those?
I think Andy and Bola have very comprehensively covered that, but I really wanted to re-emphasize that kind of approach that's about co-production and involvement of communities. And it's not just about designing, it's also about communication and inquiring and really understanding what communities and what people want and what they need. And building on the success of the COVID vaccination campaign, we're working with community connectors in our Core 20+5 program. And that's really to do two things, you know, to really understand the voice of the community and the needs of the community, but then secondly, to sort of bring the NHS into the community. So what would be described as underserved communities, that we don't allow ourselves to have groups like this, that, you know, we try and understand how we can serve them. As Bola said, we turn challenges into opportunities. And I think this approach has worked, you know, in my work as an infectious diseases consultant. In HIV, we do a lot of peer support work and co-design and co-production and community-led projects. And it feels to me like this is really where all the progress happens. And I talked about alternatives to pharmaceutical treatments. And a lot of this is around social prescribing and community activities, physical education, you know, good diets. And, you know, the heart of this knowledge is actually within communities. So part of all of this is about recognizing that innate power in communities and tapping into that and supporting it.
Brilliant, thank you very much. And kind of following on from that, we've heard some great case studies about services that are doing fabulous outreach, places like somewhere that's reaching out to homeless communities, one service that has been doing outreach into food banks to access people who are using food banks. But one of the things we're hearing a lot about is the importance of building trust with communities before you try to actually do anything. And then on the flip side of trust is we've also heard about the importance of building trust, clinicians building trust with individual patients, and the potential downsides of losing that trust and the knock-on impact. So maybe Aoife, if you want to start with this one, I don't know if you have any thoughts on either or both of those aspects of the importance of trust.
I think we're only just beginning to recognize the importance of building trust, and it feels like it's a very delicate concept, especially now with all the sort of pressures on the NHS and on wider society. But increasingly, I think building trust is recognized as really important, but also perhaps we don't give it enough time, because building trust takes much longer than our sort of traditional timelines that we use in healthcare. And so that's, you know, an impact on resource and time, and also that kind of, you know, benevolence and going the extra mile that we would need to build trust. And again, I think this is why working with communities is so important, because, you know, often it's about who delivers the message, not what the message is. And so having a trusted messenger or a community champion is really important. And increasingly, I've heard that trust is perhaps beginning to be recognized as one of the wider determinants of health. And we know that sort of health-seeking behaviors are so predictive of outcomes. And there's a lot of research from the States about having trust in the healthcare system, and then your chances of future encounters and getting your preventative care, and also the knock-on effect of poor experience of healthcare that it has not on just the one person, but on their friends and family, and the chances of them coming back again. And that's why we really focus on the experience of healthcare, and really trying to establish that trust and that confidence, that your story will be respected and recognized, and you'll be treated as you know, a valued member of society. And sadly, in healthcare inequalities, a lot of people face so much stigma, and have a lot of distrust as a result, that does take time to heal. deal. But I think, as Bola said, we're really sort of committed to action. We have the data, we know where we need to go with all this work. So it's really about rallying around and getting that culture change, and in the spirit of quality improvement.
Thanks, Aoife. And Bola, did you have anything to add to that?
Aoife has made some excellent points there, and I'm just going to build on those by saying one of the key ways of building trust is not just in terms of the conversations we have with our communities, but the actions we're seeing to be taken. And one of the examples I would give is we've developed the Health Inequalities Improvement Matrix. Now, this is a tool that should help us as we design, commission, and deploy our services, and indeed evaluate them in a way that really asks the question in a very practical way: have we actually addressed health equity? So I think the application of the Health Inequalities Improvement Planning Matrix in that way would be an active way of showing the community that we are listening and that we're taking action to bring them with us. The second is a point that Aoife has raised a number of times in her comments around communication. So we've developed some tools around culturally competent communication, especially with our socioeconomically disadvantaged populations. So again, to what extent are we applying some of those practices that we've set out within the toolkit in working with some of our disadvantaged people and communities? Thirdly, another area where people can tend to get disenfranchised is around digital offers. And there is important action we can take there. Last week, we published the framework for NHS action on digital inclusion. So how are we going to intentionally use the great case studies, the principles, the practices that we've set out in that framework to make sure that no one gets left behind? Tomorrow, we're going to be publishing the framework for inclusion health. So that community that tends to find itself at the very peripheries. So people experiencing homelessness, people in our Gypsy, Roma, traveler communities, some of our ethnic minority communities, and others. We're setting out how do we work in a mutually respectful way with these communities, and what is the role of each layer of the system. So sorry, I've gone on a bit, but this is me trying to say, to build trust, people need to see us acting differently, not only saying differently. And some of these resources that I'm calling out are tools and resources to enable us as a collective to do differently and build trust that way.
Brilliant. Thank you very much. And Andy, do you want to come in on any of that? But also, I was also thinking if you have anything to say about the trust bit between clinician and patient, healthcare professional and patient, particularly in the context of things like MSK pain, where I think that conversation can be quite tricky.
Yeah, and I just great points from Aoife and Bola, which I really agree with. I think before coming to that, there's also levels of trust. So trust is such a key element to what we're doing. It can also be quite emotive, I think. And it's about, I believe, creating a principle of shared ownership for health and care. And then we can think about that in multiple different ways. We can think about that across interprofessionally in healthcare and shared trust. We can think of it between elements of health, social care in the third sector and shared trust. We can also then think about it between, right at the coalface in a way, between clinician and patient. So trust sort of traverses a lot of the work we're doing in multiple different ways. And I think, key elements to enabling that trust is absolutely what's been referred to. You know, it's the personalised approach to care that we've talked about so widely in the MSK space. Care that is around what matters to the individual. And that needs to be thought about really through two lenses. We need to think about how care or how delivery, whether that's prevention or reactive care, is planned, designed and delivered, and how we ensure the principles of personalised care are embedded with that. And also, how do we enable people at the front line of care to create that what matters to you conversation, to create that personalised approach, and ensure that the person who is meeting the clinician feels really engaged with that, referencing what Aoife said with regard to the evidence. And that is more than publishing tools which talk about personalised care. It's really embedding a skill set to do that, which has to be learned over time and built and developed. Of course, underpinning both of those is co-production and co-design, which we talked about before. And I very much think of co-design as across stakeholders, and co-production is really working with those with lived experience, as well as best using the data to enable assurance and evaluation. But that then links with PREMS and patient-recorded outcome measures and experience measures, but showing, as Bola quite rightly says, that whether this is locally, within the system, regionally or nationally, within our sort of leadership strategy, we are reflecting on those PROMs and PREMs, and we are using them to drive quality improvement, to make sure that everybody involved in that improvement process feels engaged in it. And I think that getting those things right are absolutely key to building trust. And I think we're on a journey to do that, but that's something we need to steer.
Great, thank you very much. I probably want to start with you, Andy, on this next one, because we've heard a lot in the course of the inquiry about the importance of moving services into the community. And I think in MSK, a lot of the time that's seen as moving it into leisure centres and gyms and emphasising that kind of physical activity, which fits very well with the MSK health messaging. But as I said, we've also heard about that much more widely about things like food banks and homeless services and that sort of thing. So how can we start to think more widely about what moving MSK services into the community might mean?
Yeah, and you're absolutely right. It's a question that is very much focal at the moment. That is a good thing to start off with. We also need to define what we mean by community, because I think that's viewed in different ways by different people. I'm a clinical lead in community services. It's not about putting everything in community services. It's about community at large. And then there's the interrelationship between system, place, neighbourhood, the fuller work. There's a lot to unpick there, and how PCNs fit into it. There's a few bullet points that I'd sort of go through that I think we need to think about, many of which probably have been reflected in our conversation thus far. Firstly, we need to balance enabling health and well-being through preventative strategies with the provision of services to manage MSK conditions. So we have to think about MSK health within a community and how that fits with the management of MSK conditions. It can't just be about reactive care. Given, as Aoife quite really referenced, the big challenge of pain, and we know that, you know, if we look at the Health Foundation work and what health systems are going to look like in 2040, pain is the biggest challenge, and pain is intrinsically related to MSK. And so to help best support people manage pain, we have to consider the wide-ranging determinants of health across a population and through the individual that drive those factors across a biopsychosocial spectrum which contribute to pain. So we have to think through the lens of environmental issues, economic issues, educational issues, cultural issues, societal issues, and that is wider than healthcare. And that is a challenge because, of course, we are focused on the healthcare bit, but I think ICBs and ICSs remain the opportunity to help us address those variables. But to do that, we really need to understand local demographics, cultures, and the needs of community. So at the heart of that is absolutely what we talked about co-production and co-design, But we also need to understand what resources we have available within that community and how we can make the best use of them. And that's going to vary from place to place, and that's going to vary based on community leads. And to be brutally honest, that's wider than MSK services in leisure centres. We do need to make the best use as part of this, because what we're talking about is access of digital health technologies. And I absolutely agree with what Bola's saying. I'm right at the forefront of some of the digital health technology work in the MSK space, and I'll be really careful with my wording. It is not about digital first. For me, it's about making the best use of digital health technologies to enable delivery. We have an opportunity. Digital health technologies will work for some people. They won't work for everyone. So a system design is key to ensure that the use of digital health technologies is positioned in the right place, but we factor in the rest of system design to evaluate the impact. And it's more about access. There is something around demand, the nature of demand that comes to health services. There is a whole world of factors which digital health technologies in MSK, the introduction of FCP, the changes associated with the pandemic have had that affect the demand we're having on services. And that links with the need to support those hard to reach. If we run existing supportive self-management resources in leisure centres, we free up capacity in hospital spaces, but really we just move an offer to a certain demographic into a different place. Actually, how can we support those people who do not want to access health services, who perhaps have more significant challenges with their health and well-being from a non-health perspective, who actually could either be at greatest risk of challenges with regard to long-term MSK conditions, or actually trying to manage long-term MSK conditions and struggling. And then the baseline to all that, because there's a lot there, is looking through the lens of behavioural change. So if we take physical activity is intrinsically linked with MSK. MSK health is the ability to move, and we know that physical activity helps prevent and manage loads of conditions, as does weight management, smoking cessation, alcohol moderation. If we just create resources for physical activity, it will be the same resources for the people who already do it. What we've really got to think about is how can we inform behavioural change? How can we help people in those more sort of hard to reach groups to look at things in a different way and change health behaviours to help support their health and well-being? And that is really hard, and that's the next step. So then if you look at offering resources in leisure centres, well, that creates an access point, but how is that going to reach hard to reach communities, and how is that going to enable behavioural change? And that is the key to help us manage the future challenge we have.
Thanks, Andy. Bola, did you have anything to add to that in terms of services going out into the community?
Thank you, Sue. And I think, Andy, you've brought out some really important themes there, which I'm going to try and amplify and build on. So I think if we go back to the vision statement that we've set out in terms of how do we narrow the health inequalities gap? And the vision is exceptional quality healthcare for all by ensuring equitable access, excellent experience, and optimal outcomes. I think your question, Sue, speaks most powerfully to the first dimension of that tripartite vision statement, the equitable access. Because I think the subliminal text to your question about how do we take care into the community is the question of access. And so I think there's something we need to think about more broadly in terms of MSK services, which goes something like, what are the barriers to equitable access to MSK services for our seldom heard communities? And we can begin to then unpack what that means, because the intervention will be different depending on what it is. So for example, we've talked about communication and language barriers, which may not be anything to do with the physical location, but nevertheless gets in the way of equitable access. That could be one. Transport is another really big one. So things like the low income scheme that we have, to what extent is that socialized? You know, so we have a healthcare transport support scheme. How many people are aware of that, both as communities or indeed as providers or even commissioners? So transport can be another leg of the equitable access question. What about prescriptions? Aoife is right that, it's not so much about prescribing, but we also know that there are people who will need some prescribing. And today we launched the prescription saving schemes communication campaign. We'll put some of the links in the chat box, because we recognize that for people living with major conditions and multimorbidity, of which MSK is one, affordability of prescription is another real barrier to equitable access, hence our launching this major comms campaign. That's another dimension of it. Then we get into equitable access on the basis of accessibility in terms of location. And this is where, as Andy said, the power of the ICS comes to the fore. So what are the various estates available? Because it's not just about sports centers. One of the things that we've published is something we call Building for Health. And within Building for Health, we're pointing out that there are many players in the system that have enormous estate. The Ministry of Defense is the largest landowner in this country, followed by the NHS, followed by His Majesty's Prisons and Probation Service. What are the opportunities of working with the individual partners in the ICS to leverage our collective estate in addressing the barrier to equitable access that arises from the physical location of our services? And we've already talked about digital exclusion as another potential barrier to equitable access. So I think for me, you're right, Sue, to talk about taking care into the community where it's needed. I think if we helicopter above that, what you're getting at is, what are the barriers to equitable access, and how do we begin to name them and then structure solutions and interventions across each one of those areas?
And
Thanks, Sue.
I think, thank you. Your points about transport have come up again and again and again, both in relation to maybe rural areas where the travel distances to services are higher, but also specialist services. Particularly came up in our paediatric evidence session about parents having to take time off work to drive quite significant distances in order to access those services, because paediatric rheumatology is quite specialist and therefore quite sparsely spread. So the transport bit is definitely important. Aoife, did you have anything to add to that?
I think Andy and Bola have really sort of comprehensively addressed that. I can't really think of anything to that they haven't mentioned. Thank you.
Brilliant, thank you. And we're kind of drawing close towards the end of our hour. And one of the things that I've been struck by in doing this inquiry and asking for evidence specifically from services is the level of commitment and the desire within MSK services to do something about this and to get it right. There is no lack of wish to do it, but there is a lot of people are struggling to know where to start, what should they do, to have the confidence maybe to raise it. And so I'm just wondering if we can wrap up by asking each of you what advice you would give to a service that is sitting there thinking, we know this is an issue for us, we want to do something about how to get started. Aoife, do you want to start on that one?
Thanks very much. And I would say definitely just embrace that energy and start small and do something really, really small. In the spirit of quality improvement, we really kind of encourage a very sort of narrow focus and trying to just change one small little part of the pathway for one person. And that can kind of set off a whole movement and a whole change process. We get asked that question a lot, and I'm so keen. I just want to make a difference. I really want to do something. And I think that a big part of it is getting getting allies, getting people kind of all talking and openly, and it's in conversations where the ideas grow. So definitely asking people, asking the communities what would make things easier, what would make things better. And there's so many resources, now that are available to really tackle healthcare inequalities across our services. So it's really a case of sort of getting stuck in and really trying to make a difference. I mean, I kind of got obsessive about looking at the data on healthcare inequalities down through the ages of the NHS and at the start of the NHS, and then further and further. And we are really struggling with very pervasive inequalities. So it's going to take all of us, all working together, tirelessly to really sort of turn the tide and start making a difference and narrowing the gap. But definitely what we're seeing since COVID really sort of shone this harsh light on healthcare inequalities, we're seeing real gathering of momentum and action and some small progress that we're really seeing even at a national level. We're seeing some real differences, and so we have, for example, our accelerator sites, and they're really driving forward healthcare inequalities improvement, but starting with very, very small, single cohorts of patients and single conditions within a clinical area. So it's just to do a little small thing and really start to make a difference.
Thanks, Aoife. Bola, what are your thoughts on where should people start?
I'm just coming off mute. Great question. And yes, I'm just going to reiterate the point that Aoife has just made. We use something we call FTI to drive our work, which is focus, traction, impact. Don't try to boil the ocean, because otherwise it becomes very overwhelming. People don't see results and they give up very quickly. So if people are thinking, where do I start? I would say, don't try to reinvent the wheel. There is already a very well socialized framework for action to reach the underserved and the seldom heard, Core 20+5. Start there. Who are the Core 20 plus population groups in relation to MSK in your local area? That's the first thing. The second thing is to then think, having identified these population groups, which population group are we going to start working on? And again, be guided by the data. Who is the data telling you is having the worst experience in access, experience, or outcomes? Start there. And the third thing is learn from what others have done. So in the chat box, we've put links to healthcare inequalities improvement case studies. There's a whole raft of things that people have done. You can get lots of examples there. We would draw your attention to that. And the fourth thing I would say is secure the sponsorship of your local senior responsible officer for health inequalities. They're there, they really want to help you. Every region, every ICS, every provider organization, every PCN has a named health inequalities senior responsible officer. I would say immediately have a conversation with them so that they see how your work on MSK to reach the underserved is their business. And the point of saying that is because you then galvanize the whole ecosystem of support that is within the health inequality space, and you mobilize that behind you and what you're trying to achieve. Those would be my reflections. And don't be paralyzed by the analysis of the data. Let's crack on with what we already know.
That's fantastic advice. I am the person who tends to try and boil the ocean and get stuck. But Andy, from an MSK perspective, have you got any thoughts on where to start?
Yeah, I'd start off agreeing with my previous two speakers. I think. I think I posted two resources in the chat. there is our MSK webpage, which has all the links to our improvement frameworks, our best MSK health stuff. And that is a great place to start from an MSK perspective. There's also the NHS impact work, which is the improvement methodology being developed by the NHS, and that's worth looking at. But I would agree, there is a balance between trying to do too much and delivering on something. You know, for me, it's about building a shared purpose and vision